listening to Everyday Evidence, presented by the American Occupational Therapy Association, helping the occupational therapy practitioner apply evidence to practice. Here's your host, Matt Brandenburg.
In the United States, nearly 400,000 children are in foster care. Many have experienced neglect, instability, trauma, and most are navigating new homes, new schools, and new caregivers. Today, we're talking about the Children's Hospital of Philadelphia's investigation into how occupational therapy can enhance detection of developmental needs and provide strategies to strengthen development when included in comprehensive health assessments for children in foster care. Thank you so much for listening to AOTA's Everyday Evidence podcast. And thank you very much to our featured guests today, Dr. Kristen Fortin, Ann Ashley Field, and Judy Dawson. Can I ask you each to introduce yourself briefly to our listeners?
Sure. I am Ann Ashley Field. I am the primary occupational therapist that works in our fostering healthcare program, which takes care of children in foster care.
My name is Judy Dawson, and I'm the nurse coordinator in the fostering health program here at Children's Hospital of Philadelphia. I've been a nurse here for over 30 years. We've been running this foster care clinic for just a little over 10 years now, and it's been my favorite job so far.
And my name is Kristen Fortin. I'm a pediatrician at CHOP, and I serve as the medical director of the fostering health program.
Thank you so much for taking the time to be here today and share your knowledge and expertise with me and our listeners. You three contributed to a publication that is available in the journal Physical and Occupational Therapy in Pediatrics. Your publication is titled Occupational Therapists Enhance Comprehensive Health Assessments for Children in Foster Care. Let's go ahead and dive into this publication a little bit, as it will be the main topic of our discussion today. What developmental health concerns are most prevalent among children in foster care?
So I can answer that. So, children in foster care oftentimes experience higher rates of developmental health concerns. And this is for, multiple reasons. So they've been exposed to early adversity. There may have been inconsistent caregiving. There may have been unmet medical or developmental needs. And so we definitely have seen trends in certain aspects of development that seem to be particularly impacted. Firstly, social, emotional, and relationship development. This is one of the most prevalent areas of concern, and it's not hard to understand why. Children in foster care have experienced disrupted attachment relationships, and this can significantly impact their ability to trust caregivers, and also to regulate their emotions and to build healthy relationships. So that's one, really significant area. Secondly, we see, self-regulation and sensory processing challenges, that these are very common. And we know that early stress and trauma can have a significant influence on how our nervous system develops. And this leads to differences in children's ability to process sensory, information and to be able to respond to stress and to manage their internal states. And so as a result, many children present with difficulties in their attention, hyperactivity, emotional volatility. And I do want to call out a particular area of sensory processing that we know is significantly impacted by early trauma, and the research is showing us this. And that is interoceptive awareness. And that, of course, is our ability to recognize and interpret internal body cues that signal needs like hunger or fatigue or emotional distress. And so when children have difficulty sensing and understanding these internal signals, it greatly affects their ability to regulate their nervous system and then respond to their needs in an adaptive way. Thirdly, we frequently see delays in language development. And these delays are often related to inconsistent or limited reciprocal interactions with caregivers during critical developmental periods. In addition, we see that many children in foster care have had reduced exposure to books and being read to. And these types of experiences are really important for building vocabulary and receptive language skills. And they really are the foundation for early literacy foundations. And then finally, we see a lot of children demonstrating deficits in their visual motor integration skills. And we know that these skills are really strongly linked to academic participation and achievement. And so difficulties in this area can impact, their ability to learn to read and write, to do math, and organizational skills, all of these things being really essential for success in school.
Absolutely. Thank you for painting the picture for us, Anne Ashley. There's so many unique needs of children in foster care, and it's something I'm grateful that you're sharing with us today to educate us a little bit more on what care looks like for this population and what you're doing in Philadelphia. As a part of your publication, I read how the American Academy of Pediatrics and the Child Welfare League of America recommend care include a comprehensive health assessment within 30 days of placement. Can you give us a little bit of detail into what those comprehensive health assessments are, and specifically what makes those first 30 days such a critical window for children in foster care?
Well, children in foster care need to be seen early and often for medical care. The American Academy of Pediatrics designated children in foster care as a population with special health care needs. There's a high prevalence of unmet health care needs among children in foster care. And reasons for that include that children often enter foster care in the context of a family crisis. So in that context, they may have experienced interrupted health care, leading to medical issues that are underdiagnosed and undertreated. And as Anne Ashley just explained, we know that trauma impacts multiple aspects of health. So it's really important to address all these health issues really early so that we can then support children and families during really critical periods of development and major transitions. So the American Academy of Pediatrics guidelines include that a child should be seen within 24 to 72 hours of placement to address urgent medical needs. For example, we often find that children need their asthma medication or making sure there aren't any urgent behavioral and mental health crisis situations. And then the other guidelines are to do the comprehensive health assessment within 30 days. And for that assessment, you have more time to try to gather all the records, which is something that Judy helps us with in our clinic, really do a comprehensive review of all the past medical history, and really do a thorough medical review of all their medical needs, all their developmental needs, and mental health needs. And again, it's really important to do those early on in placement so that we can really support that child and family and make sure that that placement is successful and stable.
Absolutely. In your experience, what barriers exist to accessing development healthcare services for this population?
Yeah, Matt, there's so many different barriers for youth who are in foster care. I can touch on just a couple. One big one is there are multiple changes in caregivers. So, a caregiver can have a child and set up an appointment for, occupational therapy or whatever it might be. And then the child gets moved from their home. And that information isn't ever passed on to the new caregiver that there's an appointment or whatnot. Then it gets missed and the whole process has to start over again. Transportation in general is a really big barrier for youth in foster care. A lot of our families are older foster parents who don't drive, don't have access to cars and automobiles to get to appointments. There's also the competing needs of the child. So, for instance, one child who's in your care and foster care could have multiple issues going on, medical issues, developmental issues, and trying to prioritize those is another barrier to care, like which needs to happen first. A lot of the foster families have their own youth, their biological children in their own home, who they also are caring for. And a big thing with kids in foster care is their medical insurance. So most people don't realize this, but when a child gets placed in foster care, their medical insurance changes. So it changes from being, covered under your parents' medical insurance over to being covered by the state, quote, the state. So that change in insurance really creates a lot of barriers. So those are just a few of the things that are barriers for getting developmental health care for youth in foster care.
Thank you, Judy. A lot of those barriers are really unique to this population. There's, not just typical barriers that come with child development, but environmental barriers related to finances and insurance coverage, billing, authorization. It's a complicated system, but you three are part of a specialty clinic for children in foster care at Philadelphia Children's Hospital. What is your clinic like? And really, what motivated you to start this clinic and participate in a specialization for children in foster care?
Well, Matt, thanks for asking about our foster care clinic, because we really love our clinic and we love to talk about it. It's called the Fostering Health Program at Children's Hospital of Philadelphia. Like I said, it's been around about 10 years now. One of our colleagues actually started the program back then, but our team has really been running it since then. It's basically a comprehensive medical evaluation along with a developmental evaluation, and it's just for youth who are in foster care. So the developmental evaluation that Ann Ashley does is really critical to this assessment. No one, if you go to any other primary care appointments in any primary care doctor's office, pediatrician's office, you don't get a developmental evaluation during your checkup. And for kids in foster care, it's really critical because of the many barriers that they've already been through. Like, for instance, they change homes often. A lot of times these kids have not gone to school for many years. A lot of times they've never been to school. So we've had kids in our clinic who are 10, 11 years old who have never been to school before. So these type of things are common, unfortunately, in youth in foster care. So therefore, having this developmental evaluation is really critical to help their pediatricians and to help their caregivers understand where they are, where they're starting from, and how to get where they need to be. Our team comes together after the end of every visit, and we talk about each child individually, and we create a plan for them. And we share that plan with the caregiver, with the pediatrician, and with the youth, if at all possible, if they're old enough to be involved in the plan. So our appointments usually take a long time. They're at least an hour. We try to keep it fun for them. We give them snacks. We give them toys, and we just try to make it interesting for them, because we see kids who do not want to be here at all. We had one little boy who came in, he was 11, and he was terrified, and he did not want to come to this appointment at all. And because the last time he had been to CHOP, they admitted him. So he had horrible, memories about that. And he was so afraid to be here. But after the appointment was over, probably about an hour and a half later, he was so happy. And he said, "I love Children's Hospital of Philadelphia." So we just try and, make it fun for them and make them part of the process of coming up with a plan to get them from here to where they need to be.
Well, what important work, and especially for a population that has such unique barriers,
Right.
To be able to access a specialty service that's multidisciplinary in this way and highly skilled. How would you say occupational therapy's perspective in these evaluations contributes to the multidisciplinary team, or maybe how does it differ from say, a physician or nurse-led developmental assessment?
OT really does bring a very unique perspective to developmental evaluations, because, we focus on how a child's developmental differences affect their participation in everyday activities, things like play and learning and self-care and relationships. OTs look closely at how a child functions in their daily life and the underlying skills that support that participation. And because OT evaluations focus on real world participation, they oftentimes lead to really practical recommendations and practical strategies that can help caregivers and educators support a child's regulation and learning and engagement in daily routines. In our multidisciplinary clinic, OTs, we do our developmental testing, but beyond that, we're making careful observations related to the child's sensory processing and self-regulation and their attention skills, all of which can be significantly impacted, as we know, by trauma. And we're observing how children engage in functional activities, how they approach play, how they interact with their caregivers, how they're able able to manage the transitions that happen, throughout the appointment, because they transition, between myself for developmental testing and Judy for vision and hearing screening, and then to the doctors for their medical evaluation. Another really important aspect is that, for school age children, we complete academic screenings. And this has proved to be hugely important because it allows us to identify lagging or even absent academic skills that otherwise would go completely unnoticed. And this allows us then to advocate for additional school-based supports or further educational evaluation. This advocacy has been extremely important because the research does show us that children in foster care are more likely to have academic delays and unidentified learning differences. And so, you combine that with, additional barriers like kids in foster care have more school disruptions and they tend to miss school more because maybe their placement changes. And so, even if academic concerns, are raised, that they might move to a new school before testing is completed. Oftentimes, when foster parents, bring kids in to see us, they are really unaware of any developmental assessments. And maybe it's because, they haven't had enough time with the child to make observations. But, being able to give them the concrete information about how they performed in our standardized assessments is really eye-opening. And it's the first step in getting the child closer to what they need to support their development.
Thank you, Ann Ashley. Your clinic rocks is really what I'm gaining from this. Thank you so much for sharing these details about your process and the services you provide. What motivated you to really study and put this paper together about what happens when OT is added and how occupational therapists enhance the comprehensive health assessment?
Listening to Ann Ashley talk about the developmental needs of youth in foster care and what occupational therapy can offer to children and families, it's really intuitive that occupational therapists would be greatly beneficial to children in foster care, especially during this time when they're going through this major transition in their life. And we were so lucky to have occupational therapists in our clinic, and we're observing every day how beneficial occupational therapy is to children in foster care and their families. But when we looked at the literature, there was really not a lot about occupational therapy and foster care. So we decided to more systematically study and document the impact of occupational therapy in hopes that we could learn and also share with others. And we're also really grateful to be invited on this podcast to talk about our study, to hopefully bring more awareness about how occupational therapists can really contribute to youth in foster care.
Thank you so much, Kristen. I've been so looking forward to this interview. I mentioned to Ann Ashley earlier, I work in for a mobile outpatient clinic here in Las Vegas, Nevada, and visit families and children in foster care in their homes, and just think that your integrated clinic and specialty service is so well designed and can have such a massive impact on communities and families and individuals as well. Let's dive into this awesome study. Can you summarize the methods and design of your retrospective chart review that compared children who underwent occupational therapy assessment to those who did not?
There's so many study designs that could really capture the impacts of occupational therapy on youth in foster care. We could do qualitative studies where we interview children and families. We could also do longitudinal studies and follow over time how occupational therapy can have a long-term impact on school outcomes or placement stability, child welfare outcomes. But for this first study, we really were able to start simple and just use the data that was already available through a retrospective chart review. So in the first few years of our clinic, we didn't have occupational therapy in every clinic just because of limited availability. So just by that reason, some children didn't get an occupational therapy assessment in the first years of the clinic. And it wasn't like those children were different from the children who got the evaluation. It was really just because of availability. So we were able to use data by looking retrospectively and doing chart reviews and pulling out 2 years of patients, sort of what were their developmental needs that were identified, where they referred to in terms of developmental services. For those seen by occupational therapy, what strategies did occupational therapy provide during the clinic time? And then we were able to just use descriptive statistics to summarize what occupational therapy found. And because of that comparison group that existed with those who didn't get occupational therapy, we were also able to compare developmental referrals between children who did and did not get the OT eval.
Why specifically were you looking at those outcome measures?
Like I said, I think if we were able to get a large grant and funding, we could look at outcome measures like long-term functioning in school, child welfare outcomes like placement stability. But for this review, those were outcome measures that we had that we thought were important. So we wanted, when children are in foster care and that relationship with their foster parent is very therapeutic and very important. So we thought it would be helpful to look if having an occupational therapist would lead to get more input from occupational therapists that could help strengthen development and help foster parents to understand a child's development. So we wanted to look at that. And then we also thought that looking at referrals could be a proxy for developmental issues that were detected. So if we just use it as a proxy to say if a child got more developmental referrals, it probably reflected the fact that there was more developmental issues that were identified. So that's why we compared referrals between the two groups.
Absolutely. Thank you, Kristen. And it sounds like there's already some wonderful ideas for future directions of this study and additional research related to your clinic. Back to specifics of this study, although you found nearly 70% of children evaluated experienced at least one developmental delay. What stood out to you most in the findings of your study?
Well, the findings were in line with prior literature looking at the prevalence of developmental issues in youth in foster care. So that was about the same. And then even though we found, like you just mentioned, almost 70% of children had at least one delay, at that time of the initial visit, there were only 27% who had at least one developmental service in place. So it's really showing that while children have a lot of developmental needs, they need more help to get into the services that they need. So that was something that I think has been shown before, but what we observe in our clinic, but we really were able to document that children in foster care, there really is room to connect them with more developmental services. And then we also saw that occupational therapy was able to give families right in that office visit, that comprehensive visit, right away, give them developmental strategies to work on. Because we all know that sometimes there can be long waiting lists or barriers to getting into other developmental services or other testing. But being able to leave right away with strategies that highlight, strengths and how to continue to build strengths, and then also how to continue to work on areas that need improvement. I thought that was also a really important finding of our study.
Absolutely. Absolutely. And you've already mentioned and given us some insight into why certain domains of development, including communication and academic skills, are more commonly impacted among children in foster care. Your study also found that children evaluated by occupational therapy practitioners received significantly more referrals for developmental services. Can you talk to us a bit about that finding? What does that difference really represent clinically?
As Dr. Fortin mentioned, we did have this unique opportunity to compare, the amount of referrals that kids were getting when they saw OT versus when they weren't seeing OT. And we found that indeed kids who were seen by OT were getting more referrals for developmental services. So clinically, I think that this really reflects the distinct lens that occupational therapists bring to evaluating these kids. OT focuses closely on functional development, areas of, sensory processing and self-regulation and motor coordination, visual motor integration, and also participation in daily activities. And these are areas that they're not going to be fully captured in just a traditional medical assessment that might include a few, screening questionnaires, but is not going to, have a way of being anywhere near as detailed or as thorough as an evaluation that can be completed by an occupational therapist. So as a result, we are able to identify developmental skill gaps that might otherwise go unrecognized. In many cases, the caregivers that were bringing their foster children in for evaluation, may not have had concerns prior to the appointment. And again, it could be just because they haven't had enough time to, observe the child yet. Oftentimes we see, kids when they've only been in the home for a few days or like maybe a week. And the foster parents generally get very, very little and literally sometimes no information about the child's developmental history or their medical history. So the foster families are at, a huge disadvantage with not knowing, what this child has experienced in the past and what their skill levels are like. So our OT observations and testing is really helpful in identifying these needs because, of course, the earlier that we identify the needs and the earlier we connect to the supports, the better we can help, support these children in developing these skills that are so important for their continued development.
Absolutely. And Ashley, that touches on such an important observation from your study, being the kind of mismatch between caregiver concern and OT practitioner findings at times due to those factors that you listed. Do you have maybe an example or a case study of how you've seen this objective developmental testing can kind of change that conversation with caregivers and enable best possible service to be provided?
Yeah, absolutely, Matt. I think, I can think of many examples, actually. It has happened, more than a handful of times where a foster parent will come in with their foster child and they report, that the child is doing really well in school. The child may even be on the honor roll. And the parent just has, absolutely no concerns about academic progress. And we do, our academic screening, and we're able to see very clearly that actually the child is performing maybe numerous grades below the grade that they're actually in. And without exaggerating, we have had, 9th and 10th graders who we can see are reading at a first or second grade level. And the foster parent had no idea. And, it's hard to kind of understand, like, how could that be happening? How could this kid be on honor roll? But, you've got to think about the schools and, the amount of resources that the schools have. And in our area in Philadelphia, the schools are very under-resourced. There are more kids in a classroom than is ideal. And, teachers, don't have as many resources to give as much attention to each student as would be optimal. And we know that, the kids who are sort of, externalizing, their difficulties with their behaviors and who are, constantly, moving around because they're hyperactive or they're doing things to kind of get out of class because it's uncomfortable for them to be there. Those are the kids that they're going to pick up delays in potentially a little bit easier because they're kind of causing a ruckus, in the classroom environment. But there are a whole nother host of kids who are just sitting there and trying to be as quiet as possible and not call any attention to themselves. And these kids just, they can slip right under the radar. And we have seen that happen in so many situations. And there's kids who, overall thinking about like the general population, we know that learning differences and learning disabilities they tend to be underdiagnosed. You take dyslexia, for example, which the research now shows that as many as 1 in 5 people has dyslexia, but it is very, very underdiagnosed, so that many of those people will never be identified or told that they have dyslexia, but they will, struggle throughout their school career, and potentially make assumptions about them not having the capacity, or they're just not smart, or they must be dumb, and these kids really end up at a huge disadvantage later on in life. And this is the result of sort of the failing system that we have. And that's true for the general population. But then when you think about kids who are in foster care, who, they're in the same school system, but they don't even have a consistent caregiver who's there to keep checking up on them and, asking what they're doing in school and looking at their schoolwork and advocating for them, to say like, hey, maybe something's wrong here. Maybe we should talk to the teacher. Maybe we should ask for school testing. That is just, not on the radar for so many of these kids. And in addition to that, sadly, a lot of our kids, especially sort of our young and older adolescents, end up in, potentially a behavioral health placement for sometimes months and months. And, they then are not attending school regularly because it's not possible in that placement setting. So even, kids who may not have a learning difference, they might be, very, academically, adept, they're just physically not in school. So they're not able to learn. And then they get plopped into school 2 years later, and they're in the same, the grade according to their age, so they get put in 10th grade when the last time they were in school, they might have been in 8th grade. And, you can see how that would lead to, so many different barriers and failures, which none of it being, the child's fault.
Yeah. That absolutely. Thank you, Ann Ashley. It's these comprehensive assessments are so important. And I want to ask, for your expertise, what are some kind of recommendations and tips for providers to help them to identify a child's strengths and not just delays through assessments like this, in order to, change a trajectory or contribute to caregiver education?
I'm so glad you asked about that, Matt, because it's really good to bring up that a lot of the kids that we test actually do really well. And it's not always bad news. Like, we identify a lot of positive things about some of these kids that we see. There's an example. Last week, we had a young lady in here who she was only 15, and she was placed in a group home. So she wasn't even with like a foster parent, but she spent most of the last year in a behavioral health institution where she had to stay as an inpatient. So she wasn't in school at all. So from what we could really ascertain, she'd probably been out of school for close to 2 years. However, when she sat down with Ann Ashley and they did her testing, we saw that she scored above grade level on math, reading, and spelling. And she had no idea. So when we shared that information with us and told her how proud we were of her and how great she was doing, it made her feel so confident. It made her so happy, because she was really anxious about going back to school because she had not been for so long. So to tell her, not only was she where she should be, but actually above where she should be, it really helped her with her confidence and her wanting to get back to school and to be part of, the school community again. So that made us so happy. And we had another similar case of a teenage young man who had been out of school at least 2 years before he came to our clinic. And when he came to our clinic, he was exposed to our free bookshelf that Ann Ashley also sponsors here in our foster care clinic, where we have books that any child who comes to our clinic can take as many books as they want to, obviously encourage reading. Well, when we saw this young man, his name was Q, like I said, he had been out of school for a while, and he saw this bookshelf, and he was so excited about some of these books. And Ann Ashley talked to him about, oh, do you know who this author is? Do you know this one? I think you'll enjoy this book. And when he was here the first time, he was really kind of down and out. But he did leave with a few books. And actually, when he returned the following week for a follow-up, he was like a whole new kid. He was smiling. He was happy. He had told us he finished reading all of the 4 books already, and he wanted to know if he could take more. So it kind of like rediscovered like his love of reading again, when I think he had lost that not being in school for so long. And it just kind of got him back on track to, love reading again and know how important it is for you. So those are some examples of where we found some really positive things instead of a negative thing. So we were happy about that.
Absolutely. I love that idea of having a free bookshelf. What a fun way to encourage reading. Yeah.
Uh-huh.
Matt, I do want to say one other thing that I forgot to mention, and that is, we provide, the objective results of our developmental assessment and academic screening to the foster parent. And we also provide them with a letter with the results in it that they can then share with the child's school. So that if we are seeing clear evidence of academic delays, that foster parent now has that documented in a letter that they can pass off to the school. And that is, clear information about where that child is performing academically. And that is really meant to initiate, a process for the school to do further testing and, put in a plan for an IEP if appropriate. And I think that has really proven to be very helpful for foster parents because it's something that's concrete that we're putting in their hand. And then they have an action plan of like, okay, I got to get this to the school. And then, that kind of starts a legal clock of like the school will have, X number of days before they have to respond in some way to this letter, which is requesting that they do some more testing for this student.
Thank you for mentioning that. What an important piece and another aspect of care coordination in your clinic that is empowering and educating caregivers. And I would imagine improving follow-up and continued improvement when kids are, months removed from their initial assessment and seeing you in the clinic.
Absolutely.
I love that. In your study, it's highlighted that occupational therapy providers or practitioners provided developmental strengthening strategies to 74% of children evaluated. I think Kristen mentioned that, this is something providers are doing in your clinic, giving strategies in that moment of assessment to caregivers, to children in foster care. What makes this finding so significant?
You're right, Matt. And Dr. Fortin did allude to this a little earlier in our conversation. But like we've been talking about the whole time, our occupational therapists can really assess very accurately some strengths and weaknesses in the youth that we see here in foster care clinic. A lot of times we'll see a deficiency in like visual motor skills. When that happens, we actually have toys here that are specifically geared to help improve those deficits that we can give to the family while they're here. We get donations of toys and things, and we request specific ones so that we can give them to families so they can take these things home. And not just toys, we also have workbooks and flashcards, all types of things like that we can identify the child's weakness, and we can talk with the foster parent about it and give them tools to start working on this at home. Many times, even though we refer for services after the child's seen in our clinic and we kind of know where they need help, that help isn't readily available. There's wait lists, and it often takes weeks and months to get services in place. So if we teach the foster parents what they can be doing at home in the meantime, it really gives the child a jump start on working on, the issues that are at hand. Like I said, when they're school age kids, it's more like workbooks and telling them, Sudoku and which actual activities are good for specific issues. And then another thing, like Ann Ashley alluded to, we simply can talk to them about like self-care skills. Like, does the child know how to brush his teeth? We can ask the child, do you know how to tie your shoes or zip your zippers? And if they don't, we can speak with the parents about that and give them strategies for helping the kids to do better in those areas as well. So there's lots of things that we do here that I don't think that they would get in another clinic that like are specifically addressing the child's unique needs.
I love that. Thank you, Judy. What kinds of strategies have you seen to be most impactful in homes that are experiencing instability?
I would say really, simple and concrete strategies and things that are, immediately actionable. So for example, when we see kids and we identify, they have visual motor deficits and, say it's like a toddler, we're able, because we have, worked on, relationships throughout the hospital. We've, been the recipient of other departments who will give us donations from time to time. And so we have a closet of not only books, but also developmentally stimulating toys. So, things like blocks and ring stackers and simple puzzles. And so many of, the kids that we see have not had a lot of access to these sort of manipulative type of toys, because unfortunately today there's so much emphasis on electronic toys, where you push a button and it lights up and it sings a song. And that actually, encourages the child to be more passive. They don't really have to work at, making the toy do something, and they're not really manipulating it and exploring it the same way that kind of more old fashioned toys like blocks and puzzles and shape sorters, used to do. So by having sort of a stash of these types of toys that we can give to families and explain to caregivers, like, this is why these types of toys are so important. And this is why, these other toys that are, very electronically based, you really don't need them, or save it for like a time when you're, trying to like get dinner on or something, or for like when you're going to a medical appointment. Giving them like those sort of concrete, simple and actionable strategies, I think really helps the caregiver to feel empowered, that they, have the tools that they need to support the child.
I love that. Thank you so much, Ann Ashley. And a follow-up related to that question, how does this level of caregiver education end up functioning as a developmental intervention?
Oh my gosh, it is so critical. And, a good portion of our visit, is spent talking to the caregiver about sort of what the findings are and what the recommendations are. And that is, so important because, our foster parents, they have so much on their plate, with this child who, they're taking care of all of their, their basic needs, their housing, their clothing, their, feeding them. They're making sure they go to school. And that's a lot to put on their plate. But then on top of that, you share like, oh, also, these are some delays that we need to kind of get addressed. And also there's the emotional point of sort of these kids have gone through so much with this transition away from their previous placement or maybe from their biological family. And now, they're with you, and all of these things, need to be addressed. And so it's very common for our foster parents to feel very overwhelmed because it really is so much. But the time that we spend with them talking about these issues, and we provide them with a lot of written documentation about our recommendations, and we give them a lot of resources to understand more about, the deficits that, are identified, and to, for example, support, we did one of the projects that we did was we really looked at how can we support foster parents in doing more reading activities in the home, because we do know that kids that are in foster care have had less exposure to books and being read to, and we see how this can impact literacy. And we wanted to share with our caregivers the importance of small things that they could do at home to make, looking at books just part of the daily routine, and to share with them the immense impact that can have for the child, long term. So, through a project, we collected information about the reading habits of foster parents and whether or not they, belong to a library and how often they visited the library. And we created an educational brochure to review with our caregivers that talks about the critical importance that they can have by encouraging, literacy types of activities and spending time looking at books and talking about stories. And it also provides a range of different types of activities that they can use with kids, based on the child's age. It gives different types of activity ideas for them to support literacy in the kids that they're caring for. And it's just giving them another tool and another resource that they can use not only with that child that's in front of us, but with the next child that they are taking care of, because most of our foster families, have taken care of many children and will continue to take care of many children in the future.
Wow, I love that. Thank you so much, Ann Ashley. And again, I just want to thank all three of you for being full-time providers and clinicians and taking the time to conduct and publish a study as important and as comprehensive as this one isn't easy to do. So thank you for your effort and your time to do that. I'd love to zoom out just a little bit and discuss some of the systems level and policy implications that your research and the work that you do in the clinic day to day can have. And I want to start with this question. If you were advising state child welfare systems, what would you recommend regarding occupational therapy inclusion in community health assessment teams?
Hopefully, so far, you've seen the great need and the great benefit of occupational therapy for youth in foster care. So we'd really advocate for policies that support access to these developmental services for children in foster care. So first, making sure insurance could cover not only the cost of the occupational therapy evaluation and then all the recommended developmental services, but also costs associated with care coordination. So we're really blessed to have philanthropy that supports Judy, and Judy's able to provide so much care coordination for the children we see in our clinic. So if Ann Ashley sees the child and we really feel like they need speech therapy, Judy's able to help connect them quickly with the speech therapy. And if the child has multiple appointments, Judy can help coordinate to make sure they're all on that same day. So that's really important to have that care coordination piece as well. We'd also want policies that could support family time. So when children are recommended for occupational therapy or speech therapy, that can usually involve multiple sessions, and caregivers have need for supports as well. There's all different types of foster care. We see a lot of kinship families, which means that a child's placed with a family member or close family friend. And a lot of times that happens in a time of crisis, unexpectedly. So, for example, we saw a grandmother who overnight became the primary caregiver for 4 grandchildren, from an infant to a teenager. And she also had to continue working. So policies that could help support foster families to be able to take time out for work, to go to the appointments, to have financial compensation through benefits like TANF, so that they could have extra supports for, if they are missing work or for transportation and all the costs associated. And then finally, there are wonderful existing programs like early intervention and Head Start, and those provide access to developmental services. And with early intervention being home-based and daycare-based, it really does help decrease some of the barriers. So we want policies to make sure that all children in foster care access these services, and see if they could be expanded, for foster care to allow for older ages, or really make sure that children in foster care have access to the developmental services they need.
Absolutely. Thank you, Dr. Fortin, for highlighting some of those recommendations. Your clinic and model is so well organized. How would you say that it supports health equity?
Judy talked earlier about the multiple barriers that children experience when they're trying to access care and they're in foster care. So having a clinic where we can really focus on children in foster care to make sure that we have extra time and a multidisciplinary team to really identify all their needs is so helpful. And really, Judy, having her be able to help the families with care coordination and navigate the barriers that come up is so important. And like Judy mentioned, she's been a nurse for 30 years and she's such an amazing advocate for our patients. So having Judy is in and of itself a way to improve access. We also are able to provide a lot of supports to families in addition to care coordination that Judy can maybe describe a little.
Yeah, Matt, thank you, Kristen. We're very aware of the population that we serve, and we're aware of the limitations and things they need. So when they come here to CHOP, we're able to provide free parking passes for all of our families that come to our clinic. We have a lot of families, as I mentioned earlier, that are with elder foster parents who don't drive and don't have access to cars. So recently we were given a donation that our team requested that donation be used strictly for transportation issues for our families, because literally getting here was the barrier. So we now are able to provide Uber rides for our families, round-trip Uber rides to come here to our clinic to be seen. We also are able to use those funds to get them to their primary care appointments or to any specialty care appointments that they have to get to, because we know if they can't get to our appointment, they certainly can't get to the other appointments. So we do set up those rides for them to ensure that the child will be seen. While they're here in our clinic, we have some very generous donations of people who send over snacks and water bottles that we like to provide for the kids, because it seems like they always arrive hungry and they're here for a while. So we like to keep them, comfortable while they're here. And we also are able to provide gift cards for our families so that they could get formula that they need. A lot of times when a new baby is placed with a foster parent, even if they may qualify for WIC or whatever, they don't have that in place yet. And formula is so expensive. We had a foster mom in just last week who we gave her a gift card for grocery store to get more formula. And she literally teared up just saying, like, you cannot believe like how expensive formula is and how much this is going to help. So we're very aware of our population, and we try and meet them where they are to keep our foster care clinic patient friendly for them.
I love that. Every clinic needs a Judy.
Oh, it does. It's true.
Yeah.
Yes, that is true.
Thank you so much. What are the next research questions that this study opens? What's something that you'd like to investigate further?
So I did mention a little bit about sort of how we're looking into literacy experiences within the foster home, and that is something that we're hoping to be able to answer some of those questions about sort of, okay, if we give caregivers this information and if we give kids these books that they're able to pick out themselves, will we see an increase in interest in reading, and will that have an impact down the line? So that's something that's sort of like the top of my mind, because I have seen, from firsthand, sort of the excitement in a child's eyes when we roll in our library cart that's jam-packed with books of all different kinds. And, they're told like, yeah, you can pick out as many as you like. That has been such a powerful tool to be able to give to kids and to their caregivers. And we know, it might be sort of a cliche, but, a single book can change a life. It doesn't always, but it can. And we've seen a few examples of how we really felt like a book had a really positive impact on a patient before. And so we would love to, continue to work towards gathering qualitative and quantitative information about how impactful that can be, so that hopefully we can expand the program, and hopefully other programs can do make some similar actions to support literacy for these kids, because it really is so incredibly important.
I love that. Thank you, Anne Ashley. That's a wonderful direction for future research. How would you say other provider types or disciplines could compare or collaborate in this model or a similar model?
So we're really lucky that we do collaborate with other rehab disciplines like physical therapy, speech therapy, audiology. And one of the things that we were able to do is attend some of their meetings and give some presentations about the special healthcare needs of foster care to really help the collaboration. And one thing, for example, that came up is in our hospital, foster parents don't have access to the patient portal. So some of the rehab disciplines were communicating care plans through that patient portal. So just knowing that's not a good strategy for youth in foster care really helped to improve delivery of services. And we're also really lucky that the speech therapy and other physical therapy, audiology, really give our patients a special priority. They realize how urgent it is for children in foster care to get the services that they need. So that's another way that we collaborate. So when children are in foster care, the hope is that they can have one stable placement during their time in foster care, as opposed to having disruptive placements and needing to move to different placements. And we've had examples where getting a child connected with speech therapy helped to maintain a placement. There was a patient who really didn't have strong communication skills and was having a lot of behavioral challenges. And when she was able to see speech therapy, the speech therapist taught some sign language that really decreased the tantrums and really improved the relationship between the child and the foster parent. And that helps to really solidify the placement stability. And we collaborate a lot because we're able to share the evaluation, all the work that Anne Ashley did with the other providers. So I'm really working together is really maximizes what we can do to help children and families.
Absolutely. I love that spirit of collaboration among healthcare professionals, and it can have such a massive impact, like you mentioned, Dr. Fortin. What can pediatric healthcare providers do to better support children in foster care?
Well, I'll answer in regards to pediatric OTs, and then I'll let Judy and Kristen, add if they would like to. But, from a pediatric OT standpoint, I would just say that, we do have such a tremendously important role in supporting kids that are in foster care, not only because we are able to identify the developmental gaps or the lagging skills, but also because we have a unique perspective in being able to understand how the child's previous experiences have shaped the way that they learn and the way that they relate to others and the way that they engage with the world. And so we can become a really powerful advocate for that child. Children who have experienced trauma and neglect, they have developed adaptations that were necessary for their survival in an unpredictable environment. And, a lot of times those adaptations look like undesirable behaviors. And that can be really challenging for foster parents and for other adults and teachers to try to understand and to try to manage, because traditional behavioral techniques that you might use with a child that might be appropriate for a child who has not experienced significant trauma and neglect really aren't appropriate and can be much more damaging to kids who have experienced trauma and neglect. And so we serve a really important role in educating others about that. At the core of a child's development is their sense of safety and connection. It's the single most important factor in supporting a child's ability to learn, is to help them feel safe, to help them feel seen, and to help them feel loved. And when a child experiences that level of security, then they're able to engage in exploration and play and relationships and all of those experiences that are how children learn all the important skills that they need. And without that foundation, it is really hard for children to really access their developmental potential. So, we play a really important role in educating caregivers and educating other adults that are involved in the child's life. And one of the most practical and impactful ways we can support these families is through caregiver education and coaching, and by helping caregivers recognize how trauma can manifest in different behaviors that are challenging, and emotional dysregulation and attention limitations, and sometimes like food hoarding behaviors, for example, and helping shift the lens of why is this child acting this way, to, oh, this is why they're acting that way. It's because of their previous experiences. And it allows them to better be able to respond in a way that is going to help that child heal from those experiences that they've had.
I love that. Thank you so much, Ann Ashley. Judy, Dr. Fortin, were there additional recommendations you wanted to provide to other providers to better support children in foster care?
Yeah, I thank everyone for listening, because by listening to this podcast, you're already learning more about the special health care needs of youth in foster care. And that includes that children in foster care need to be seen earlier and often. So they need more additional visits. And we also talked about supports that could help, like help with transportation or help with care coordination that could really help. And I would really emphasize what Ann Ashley said about providers being able to recognize the role of trauma on health and be able to really strengthen the relational health between children and their caregivers. It can make a huge impact.
One thing I would like to add for caregivers or providers who take care of youth who are placed in foster care is just to be a little more flexible, like with scheduling appointments, with, expediting appointments. I've seen a lot in my experiences where we see a youth who's been placed in care, and then when you call back the primary care provider to try and get them back in for an appointment, the family's told they can't be seen because they missed too many appointments. Just kind of things like that are not, that's not the child's fault, and the child should not be punished for something like that, but that literally happens. So one thing I would say is for caregivers and office personnel to be a little more flexible. And finally, I think they really need to give a little grace to our foster parents. These people are taking care of kids that they usually don't even know their last name, let alone the child's date of birth. And they took this child into their own home, and most of these kids have so much baggage and so much going on, and this parent's just trying to help. And I see way too often that they're given a lot of, not as much grace as they really need to be given. So those would be two of my suggestions for people who care for our youth in foster care.
And Matt, I will add one other thing. This is kind of back to the conversation about policy change, but we would love to see it if placement in foster care would automatically trigger a 504 plan for a child in their school, because it would be so beneficial for everybody. That's, sometimes school is the one thing that hasn't changed for that child. And, hopefully they haven't had to change schools, and to involve, the teachers and the other school personnel that are seeing this child every day and that know this child, for them to recognize, oh, hey, this thing has happened with Johnny, and Johnny's now staying with Mrs. and Mr. So-and-so. Let's really be mindful of how he's doing, and let's be, checking in on him, and let's be, paying extra attention to how he's doing in school, and let's communicate with the foster parent about things that we're seeing. That kind of sort of extra support it would be so, it would really change things a lot for many kids in foster care, and it would really help support them in so many ways that they're not getting now, unfortunately. So we would love to see that.
Absolutely. Those are such powerful recommendations. And thank you for sharing your tips, your insight. Are there additional resources, training, or communities of practice, perhaps, that you would recommend to clinicians who want to learn more about your work?
I can share some resources for listeners who want to learn more about foster care and the medical needs of youth in foster care. We do have a website for our clinic and a clinical pathway that tells a little bit about what we do in our clinic and links to other resources. Some of the resources it links to includes lived experience perspectives, which I think is so important to hear from people who have experienced foster care. There's some great podcasts out there that people could listen to really understand that perspective. There's also a lot of resources available through the American Academy of Pediatrics. There's a recently published textbook called Fostering Health that gives a really comprehensive overview of the healthcare needs of youth in foster care. There's over 50 different chapters. And the American Academy of Pediatrics has a special council dedicated to foster care. It's called the Council on Foster Care, Adoption, and Kinship Care, also sometimes referred to as Coffee Cake. And if you go to their website, it will link to a lot of resources that include some of those AP guidelines that I was talking about that really detail all the needs of youth in foster care and the different types of visits that are recommended. So those are some great ways to learn more about the needs of youth in foster care. And Ashley could share some resources about occupational therapy and trauma.
Yeah, so there is a really amazing text that I highly recommend. It's called Trauma, Occupation, and Participation, Considerations in Occupational Therapy. And it's by Amy Lynch and Rachel Ashcroft. And it is available on the AOTA website. And it is, it's just completely filled with really important and useful information about how trauma impacts everyday occupations. I would also recommend listeners who are interested check out Kelly Maller, who is very well known in the sort of interoception world. And she has some great resources that talk about interoception and trauma. She has some videos on her website. She also has some written materials. And there is a book by Marty Smith called Sensory Healing After Developmental Trauma. And I would also recommend checking that out.
Thank you so much. These are wonderful resources. And Ashley, Judy, Dr. Fortin, this has been such a wonderful interview again. I just have one last reflection that I want to ask each of you. What do you hope that policymakers, clinicians, and educators take away from this work and what you've shared with us today?
So I really hope that policymakers and clinicians and educators will recognize that children in foster care oftentimes require additional developmental supports and closer follow-up. And this really should be the norm rather than the exception. Because of the disruptions and adversity that these children have experienced, the developmental concerns can easily go unrecognized without this intentional screening and this strong coordination of care. It's also so important to acknowledge the profound impact that removal from a primary caregiver can have on a child's overall functioning, regardless of, whether that environment was healthy or not. The emotional and relational trauma associated with entering foster care is really significant. Yet, unfortunately, many children don't receive sufficient therapeutic supports to help them understand and process those changes. And I mentioned before how I think that it would be a huge advantage if kids were automatically given a 504 plan when a child enters foster care. And this could really help ensure the early coordination between school counselors and teachers, case managers, and the foster parents, so that, they're able to provide structured academic monitoring and emotional supports in an environment that the child is familiar with. And then ultimately, supporting children in foster care requires more than identifying developmental delays. It also requires ensuring that families and caregivers have access to the resources and the services and the coordinated systems of care needed to help these children heal and to learn and to reach their full potential.
I love that. Thank you so much, Anne Ashley. Judy, Kristen, are there additional takeaways that you're hoping our listeners can glean from your work?
Yes. I mean, in addition to everything that Anne Ashley just mentioned, I wholeheartedly agree with every single point. In my perspective, from what I do in this role, what I would really like to see change is the problem with the insurance, with the medical insurance. I don't think that people understand how complicated it is for the families. Families usually don't have any idea what the child's medical insurance is or where they're capitated to for primary care. And those sort of things are just, it's not really acceptable because the child is placed with them and it's their responsibility to get the child the medical care they need and the services they need. However, they don't always have access to the medical information, the medical insurance information, so that they can do that job. So that would be one thing that would be top of my list. And that ties right into getting a primary care provider that is appropriate for a youth in foster care. So not every primary care provider is the appropriate one for youth in foster care. So those would be my two big things.
Today, I'm glad we had a chance to talk about the importance of identifying strengths and how important that is, and how when we do identify needs, that the role we can play to make them improve and turn them into strengths really is so important. So I would say for clinicians and educators to also be able to focus on strengths from the youth and the family and the relationship between the child and their caregivers is really important. And any supports that we can provide to support the families, like we talked about some of the concrete supports or policies that could help better support the youth in foster care and their families.
I love that. Thank you so much, all three of you, for your time. I really appreciate everything you've shared with us today. It's been a real pleasure learning from you.
Thank you so much for having us, Matt.
Thanks for listening to Everyday Evidence. Tune in next time for more evidence-based practice insights and applications.